One out of three adults have prediabetes, and 1 out of 10 adults have type 2 diabetes. We have a lot of weight management clinics. So, as an endocrinologist, there are a lot of weight management clinics that I have run. And there are a lot of primary care physicians taking the aspect of preventive health care system and have annual health checkups. But what we've realized is that the burden of type 2 diabetes and lifestyle disorders keeps on rising. So there is this unanswered question, even for doctors, that what do we do? What is that missing link for us that we're not able to answer so far? Today, we have Dr. Todd Smith with us. He is a renowned expert in family medicine, and he's worked in a lot of leadership positions as a medical director. And currently, he's the medical director in one of the hospitals in the Twin Cities. I would like to welcome Dr. Todd Smith, and it's a delight to have you. And I'm looking forward to hearing a lot of your stories and insights from you. Welcome.
Well, thank you very much, Dr. Arora, and I'm happy to be here today. Looking forward to the discussion. It's a topic that's very important and timely, as it always is, and a big problem in the US as well as across the world.
Yes, absolutely. So we'll dive right in into the topic, and I would like to hear your insights about um, what is the current preventive healthcare system, and is it really playing its true part in the United States?
The brief answer, I think, is no. Having been a family practice trained physician for longer than I care to admit, looking at 25 years or so, I have had large panels of patients, and I have diagnosed a lot of people with diabetes and managed people with diabetes. Preventive care in the US is in a really interesting position right now. I think that we have tried to do the best that we can with the resources that we have. I think that there's a big demand on primary care providers in the US, in this country, in this state. There's more demand than there is supply, first of all, of physicians and providers. And I think to do this, so we're going to get into this a little later, I think, but we're going to talk about different care models and how we can help physicians and providers to do what the preventative care that needs to be done. So right now, I don't think there's adequate time in a physician or a provider's schedule every day to really do the work that needs to be done to do it well. Do we do it? We do it, and we do it okay. I think there's a lot of room for improvement, and that's using using technology, using AI, using different roles that providers don't. When I say providers, I mean physicians and nurse practitioners and physician assistants, kind of prescribers. But the word we use a lot is providers, so that's what I mean when I say providers. That we can take some of that work off of providers that doesn't need to be provider work. So we work as a care team rather than just having the physician or provider have to do all the work, because it just can't be done. There's not enough hours in the day.
You bring up a very good point, Dr. Smith, and then that's what my next point would be. Like, so there are these allotted time slots that we have for our patients. So if we talk about type 2 diabetes, and then they have chronic kidney disease and other complexities, yes, we have a little more time dedicated to them. But then we also have those people who are coming in with pre-diabetes and then just a higher weight. And then we have a little lesser time that we are allotted towards them. But then if we think about it, like for people who have pre-diabetes, they also have a lot of other psychosocial aspects that are involved in the development of their disease. And even if we talk about a higher weight, what was the thing that led them to in this situation is one question, but we're not able to cover all these aspects when we're talking about the time slot as such. So, what is your take on it, and how is it as doctors or even the patients coming to us that we can help them in our limited time slot, uh, you know, perspective like that we have? How is it that we could help them?
Yeah. And that's the big quandary, right? I mean, you have, a primary care provider will have 20 people on their schedule in a day, and you get maybe 15, 20 minutes with them. You can't effectively diagnose, treat, prevent all of that in a 15, 20-minute visit. So it gets to be the challenge of, so you talked about kind of a broad swath there, but for someone we don't know has diabetes or pre-diabetes, you're doing their physical and it just happens to come up that, they have a family history, or, they're a little thirstier these days. And so you do some blood work. So that's step one, right? And we're diagnosing diabetes a lot more and earlier, which is good, but then that also leads to more patients that have diabetes that are on my panel as a primary care physician. So then I have more patients coming in for follow-ups. But traditionally, so you have old world thinking and new world thinking, let's just say. In the past, in my past, when I would manage these folks, I would see them every 3 months for maybe 20 minutes. We would talk about how things are going. We'd do an exam, we'd do labs, and off they go. And that's just repeated every quarter. Maybe a new way of thinking is we have multiple touch points to these patients in between those visits, right? So maybe they're virtual visits that the nurse gets on the line with them, a video call, and says, "How are you doing? Show me your insulin, how you draw it up, make sure their technique is right. Show me your medicine bag that you have, make sure the medicines that we have on the record are the same. We have a dietitian, make contact with them. Tell me how, you're eating. Talk about a diet and exercise plan." So these are things that can't be done practically in a 15 to 20-minute doctor slash provider appointment. And if we're going to really effect good diabetic teaching, training, maintenance, prevention, treatment, it takes more than just one person seeing a person every 3 months for 15 or 20 minutes.
Absolutely. And you bring up a very good point that we need those multiple touch points. And there are a lot of disciplines that go into the aspect of the care of each person who has diabetes. So there may be an individual who has type 2 diabetes, but has a very strong craving sensation whenever they're upset. And this may go back to their past history where they didn't have their parents around with them, and the only comfort they found was food, and that's
Right.
why those cravings developed. Or maybe there is a lady who's work from home, she's busy all day, she doesn't have time for herself, she's not able to sleep well, and then she has to cook for her family, so she doesn't really have time for being very active, and then again she's losing on her sleep. So there are a lot of disciplines that are going in the care of diabetes management that we're missing on these usual appointments in these 15 to 20-minute slots. So that's why the role of multidisciplinary aspects or a care team that is needed for the management. And so how you already touched upon it, but how is it that we can actually implement it, or how is it without affecting the day-to-day routine of the individual, where they have to go to different individuals or specialists from here to there? How is it that they can imbibe it and better care for their diabetes?
Yeah, I think that that's a great question because, right, we don't want to be harassing these folks, every week with a video call or with a phone call or a doctor's visit, driving all over town. In my experience, I led primary care, and then just spent some time in IT at one of the organizations here in town. So I have a lot of thoughts about, using technology for this. I think there's a vast land out there that needs to be explored to use this. I think that we could use certainly applications on, everybody carries around these smartphones now, practically everybody. Uh, let's try to find out how to use that technology. Let's try to figure out, are there wearables that people could, have at home that gives data through their smart device that uploads then to me and my care team daily weights. So we have a scale that's integrated to an app that sends me their weight, and I see if they go up 2 or 3 pounds in a day. That's going to send an alert to me as their provider. I think that if we can do things between those 90-day 15-minute visits that slide into the patient's regular day, that aren't obtrusive to them, and they don't need to remember, oh, I have to go onto the app and enter my weight now. That is everything we rely on for human memory is a
Yes.
potential for a sliding back. And so if we can make it easy, and we can make it unobtrusive, and we can make it something that the patient sees value for, right? That is how we can really do well. To your point, so much of chronic illness has an overlay of mental well-being and wellness, and I've seen it every day in my primary care practice. Folks who really have a good grasp mentally of their life, but also of their illness, and they get it, and they don't have confounding factors of, I don't know, a bad home life or financial stress or, all those other things that you mentioned. They do better. So how can we support those folks? And I've had patients say, when I've challenged them on that, say, let me get you to someone like a counselor or someone you can talk to. Oh, I don't have anything wrong with me. Mentally, I'm fine. There's a, and I will be very regionalistic here, but upper Midwest, very stoic people who don't feel like they need help with anything. No, I got it. I'm okay. And so you have to sort of get past that and help them to realize, oh, well, maybe I do need to talk about this and talk about my mental well-being. It's a huge part to me of any chronic illness, is someone's mental well-being. And that goes along with exercise then, which can also help with that, and eating right. So it's all a big package. And I think we're going to get into it a little bit too, but my focus always with these people was, I have medicines that'll bring your blood sugar down. I can give you medicine. I can give you insulin. I can give you metformin. I can give you these new GLP-1 drugs. But first, let's talk about exercise. Let's talk about eating better food. Let's talk about, doing these things that are going to have to be the base of the pyramid of treatment, right? Everybody with prediabetes, or really everybody, should be exercising regularly and eating better, clean eating, and all of that sort of thing, healthy mental well-being. That's the foundation you build any treatment of any chronic disease to me. Then you start talking about, okay, well, let's monitor the blood. Let's talk about medications. And so you build it on that sort of pyramid. At least in my mind, that's how I always would go about it.
You bring up another excellent point, and there's a lot of insights that you've already shared. But then, um, would you want to touch upon the indifference that people develop once they have developed type 2 diabetes? So initially, they're in that phase of, right now I'm in an urgency that I need to be taken care of, because now from pre-diabetes, I've reached a stage of type 2 diabetes,
Right.
and I'm like emotionally burnt out because now I have this condition. But after some time, there's an indifference that sets in, and then
Yeah.
I don't really care, because whatever I do, it's not going to go away. That's
Right.
what how everybody kind of approaches it. So what is it from that aspect as doctors? Because when we keep telling them, okay, do this, do that, you need to fix your diet, you need to fix your lifestyle, you need to do this. I mean, we keep giving these advices, but ultimately they don't really register, is what we
Right.
feel like. We
Right.
just feel like, what is it that I can do to make you do these things? And I mean, if we relate it to ourselves also, like, it's very difficult to break a chain of habits that we have developed. So what is it that we should probably work on in terms of healthcare providers to help
Yep.
them?
That is so hard. And that's really kind of the $1 million question. My experience, and we'll talk first about the why. It's easy to be bad. It's hard to be good. So bad food, I'll just call it bad food, is cheap and it's easy to get and it's everywhere. And now I can have really horrible junk food, Ubered to my doorstep, right? I don't even have to get off the couch. I don't have to go with the car. Where if I'm going to cook for my family and for me in a healthy way, I got to go to the market. I got to get fresh vegetables. I got to get, things that are healthier for me, lean protein, all of that. It's just easy to get on your phone and order Uber Eats from, McDonald's. Um, so it takes energy. It's that I got to put in energy to get up over that hill. And humans do respond to demonstrable effects, right? So if I can demonstrate to you, so Dr. Aurora, if you do this and you do that, now you come back in 3 months, your A1C is going to be lower next time if you do X, Y, and Z, and you're compliant and taking your medicines every day. And then they come back in 3 months and it's not. And then I say to them, well, tell me about your diet. Tell me, okay, that's not what we talked about. Tell me about your exercise. Oh, you really haven't done much exercise. Okay, I'm doing, I'm trying to help you, but I need you to help yourself. And so the next time they say, okay, I'm going to really buckle down and do it, and they do bring their A1C down, then they're like, oh, I guess this does kind of work. It's obviously it's not that simple, but what I tell people, I try to get to them early in their diagnosis to say this diabetes, think of it as a mountain or a hill in front of you. Okay, you're going to have to get to the top of it so you can try to get on the other side. At first, if you do it, that road is smooth and gentle. Okay, if you put it off, that hill's still there, but the road to the top gets steeper, right? So it's harder to get there if you don't start early. And once your A1C is 14, then help someone help you because that's going to be really, really hard. And but on the other hand of that, just as what you talked about, you sometimes get to a point with a patient where they're like, I can't do it. I don't know what to do. I can't, nothing's working, nothing's helping. And then you're to the point of, okay, maybe I can get you to someone who can help mentally try to sort of, accept and adjust to this. So some people just don't want to hear it, and they're like, "I don't have diabetes. That's a bunch of baloney. I don't trust you, doctor." Well, okay, but here's the numbers, and this is what it is. I think families also play a big part. If you're the only one in your family eating like a diabetic, and nobody else is, that's going to be really, really hard. So the new diabetic has a lot of barriers that they have to work through. And I think as providers, you acknowledge that and you say, I get it, this person is very tough, but in their life, things are really hard. And they've always eaten this way all their life. And their mom and dad are probably diabetic, right? And it's a major, major shift to try to get them to shift. So it's not a great answer. I don't have all the answers, but I think working individually, and this is also another reason why we really have to start talking about care teams, because, if you have a nurse who can work with someone who really knows them really well, they can spend more time with them than I can as a provider. And I think if patients feel like we're invested in them, in the healthcare community, they'll respond better. And if we say to them, look, here's an app that really could help you. It's really easy to use. Here's how you log in, and I'm going to, help you set this up. Maybe you even have someone at the clinic who sets them up on an app, or two. And here's how you get a scale for very little money that can hook up to this app. So I think there are ways that we can work through that, but it's going to take different thinking about how we treat these folks.
Right. Very insightful. And I like the point that, if we have the family that's involved, then it becomes much easier. So, as
Huge.
yes, yes, because it's just one person dealing with it, and the one person is the one who's trying to do their best in eating healthy versus the other people in the family are not helping the
Yeah,
situation. So it has to be a family affair. And when it becomes a family affair, then the whole family's health actually ends up improving. So bang on, right?
exactly.
Yeah.
I To use an analogy or a similar thing, if I have someone who comes in and wants to stop smoking, my first thing is, does anyone else in the house smoke? Well, they have to quit too, because
Right.
you're not probably not going to have a big chance of success if the wife stops smoking, but the husband is still sitting there lighting up cigarettes right in her face. So, in the same way, it's a family effort to tackle this. And you're right, you elevate the health of everybody in the family if you start eating healthier and exercising, which is something you can do together. You can take the dog for a walk every day, and it's not a lot. The dog's happier, and eventually you both feel better too.
Yeah, yeah. I think it has to be a social affair. Like,
Yeah,
having friends,
yeah,
friends also does
right.
help. Like, this, yes, yeah.
Absolutely. Yeah.
So, Dr. Smith, you had touched upon when a person who has pre-diabetes and then suddenly the onset of type 2 diabetes happens, there is this window of opportunity where the action can be, very vigorous. So we have this golden opportunity to take action, and there's a lot of, emotional draining that happens once type 2 diabetes happens. There's a lot of physical uh, physically it becomes more of a sickness once type 2 diabetes happens, and people get drained in terms of their energy levels. There's a high risk of infection, and financially again, their copays start to increase. So what is it that we can do in that period to help with this so-called diabetes reversal, and what would be the next steps that you would advise in that regards?
Yeah, great discussion point there. Let me start by going back a little bit in that to say, well, we've seen the incidence of diabetes go up and up and up, and why is that? Well, I think there's a lot of factors to that. I think we are getting better at diagnosing it. I think we're diagnosing it earlier. We've created these they've been around for a while, but pre-diabetes and metabolic syndrome and all of that sort of thing, really to try to just what you're talking about, get to these folks earlier so that we can help them really understand the process. And I used to write out a graph. I was a very visual teacher for people. You write a graph and you say, here's your blood sugars. They just are slowly elevating over time. Before we didn't see it until they got to here. Well, now we're seeing it way back here. And so, as you said, I'll say to someone who's there for their annual physical, who maybe sees me once a year, maybe even less than that, once every 2 or 3 years, and I see them have, a fasting blood sugar of 110, 110, 112, I'm like, okay, guess what? We're going to start seeing each other every 3 months now, and they're like, what? And I said, well, hold on. We want labs every 3 months. We want to check your blood sugars every 3 months and A1C, see where you're trending. You want to check in with me virtually every 6 months, maybe. We come up with a plan that's suitable to them. But the point is, we have work to do. And I tell them, you're going to get some homework assignments here. Okay. Here's some really good websites that I want you to look at. American Diabetic Association. I want you to look at the Endocrinology Society websites, mayoclinic.com. Sorry, I don't mean to, if that's bad, we can edit that out. I'll start over and not include
I think this.
mayoclinic.com. But so let's go back. That we have a lot of work to do with education, and I try to get them to some good quality websites, and I try to educate them about what's happening to their bodies. And that is something that, so I put a lot of that on them, but also we want to try to get them in to the system a little bit more, to what we talked about before. Let's have you meet with a dietitian. Now, the dietitian can spend an hour with you. I got 15 minutes to cover all this stuff. And oftentimes they'll go, oh yeah, that sounds great. That's something we probably should have done a while ago. I'm going to bring my husband with me. So, then we get them in for a dietitian visit, right? And then we get them hooked up with some other resources. We offer them mental well-being. Now, this is kind of a pie in the sky idea, but then we hook them up with if there's an app for either the health system I'm working at or external apps that are really good at this. We may know one. And we try to help them to understand what's going on. Because to your point, and then we decide, how do we monitor them? We teach them how to check their blood sugars with the finger sticks if we don't need to do it all that often. It's hard to go right to a continuous glucose monitor when they're pre-diabetic, so we usually don't do that, but we will encourage them to check their blood sugars here and there, before meals, after meals, sometimes see what the pattern is like. Again, the idea, we're accumulating data so we can make a better decision for the patient and help them to understand what's going on. It's not just for us, it's for them. We have them watch their weight. We teach them about exercise and diet. So there's a lot of things that we can intervene in this little golden window that we have. We've diagnosed them with prediabetes, but they're not, frankly, diabetics yet. To your point, there's a lot of emotional stuff that happens right then, because chances are they come from a family where they have diabetics. Chances are they know diabetics in their peer group or their friends. And so they're like, oh, now I'm going to be like Uncle Joe who lost his foot because he didn't take care of his diabetes. And, they just start spinning and going down that road. So that's where a good support system at home is important. But if they don't have that at home, or even on top of that, we can offer them mental resources, mental health resources, and help them to try to process this, go through the stages of grieving. Because if you're diagnosed with a chronic disease, you have to go through those, denial, anger, bargaining, depression, acceptance, to get to a spot where, okay, I have diabetes now, and now I need to learn how to deal with it. So I think that's that little space in there where we can really get to people and help them understand. Now I'll sit down with them and say, because almost always they say, well, am I going to have to go on insulin? Like, well, maybe not today. So there's a lot of things that we can do before we get to that, and talk about reversal. And I tell people, look, you fit the diagnosis for diabetes or pre-diabetes, but this isn't necessarily a one-way street. Now, if you have a strong family history, chances are yes, but we can delay that. We can either reverse it, or we can really flatten that mountain that I talked about, flatten it into a little hill, and then we can work our way up the hill and find our way that way to have people be able to help themselves. Uh, and it's about also setting goals, right? You just don't want to let them loose without any idea of what they're supposed to do. So setting goals, I want you to exercise 20 minutes a day per, 3 days a week, right? And write those down and bring those back in next time you come and see me, and let me see how you did.
Those SMART goals that we usually
Right.
like try to. Yes, yes.
Exactly. Attainable. Yeah, I'm not going to come up with all the acronyms right now, but yeah, there you set them. There's actually metrics around them. There's numbers set to them, not just, oh, try to exercise more. That doesn't work. You have to give them numbers and something to aim for.
Right, right. And you touched upon the continuous glucose monitoring sensor. So early on in the disease onset, even for those people who have pre-diabetes. So yes, we do have studies now showing that continuous glucose monitoring sensor is one of the behavioral modification strategies that is going to help even people who have pre-diabetes with going back in time and maybe reversing this insulin resistance that is going on in their body. What is your take on it? Because there are a lot of
Yeah.
people, even without pre-diabetes, just going for CGMs. So I mean, when is it that line that we need to define, but also like how is it that is going to help us?
Yeah. Great question. For me, I would always try to tailor that to my patient. There are some patients who just aren't going to wear those things all the time. And, you know, I'll be a little prejudicial here. It's older men, right? A lot of times that they're like, I don't need that. I don't want that. I think as, now even folks middle age, my age, are so much more tech savvy. And then especially with the millennials and the Gen Zs coming in now, they're all about that, right? They live on their phones. They want to see this kind of thing. And so if they're really motivated and really interested, I will start a CGM early. Sometimes it's a bit of an insurance battle, as you know very well, but a lot of times we can get that covered for them. And if we can, then it's wonderful. And then they're on their phones all the time and they get, bing, there's an alert. Uh-oh, your blood sugar is a little too high, right? What are you going to do about that? Or at least identify patterns. Oh man, and when I went to, Olive Garden, man, that really shot my blood sugar up, So learning from experience and how that affects your blood sugar is all part of the acceptance part of the diagnosis. Accepting, here's what I am now and here's what I have to do. And sometimes it's harder than others, but I think using a CGM can really be helpful. Now, if you have even better, if you have a CGM that hooks into an app on your phone that can do a couple of things, your app can maybe talk to your doctor's EHR system, electronic health record system, or it gives you alerts, or it compiles the data and shows you trends. Those apps can be really, really helpful to do that. And then on top of that, say, I noticed a pattern that your blood sugars are always a little high about 6 p.m. Why do you think that is? Or maybe that's something you bring to your provider. Those kind of pattern recognitions. And then we get into the world of AI and all the AI tools that we can use to really analyze the data. We keep talking about, we want a lot of data. Well, then what do we do with it? The doctors don't have time to, wade through piles and piles of numbers. We need some way to, in collaboration with these technology companies and others, how can we use AI in a smart way to help us, compile the data so that we can make really good medical decisions for these folks?
Right. You touched upon just now that you talked about, like, middle-aged men having this reluctance in
Right.
facing the CGM and using technology. But also there's a cultural aspect to, the
Absolutely.
care provider being different, and the cultural acceptance of the disease itself is there. So what are your thoughts on those?
It's huge. And, I think if you look at different cultures and different folks around the world and how we eat differently, how we exercise differently, how our cultures are different around familial tendencies to all play a sick role, or who plays the sick role, or and who does all the cooking and who is expected to manage all of this. It has huge implications. And I think we're just on the cusp of understanding that. And here in Minneapolis, we have an enormous Somali population and a lot of folks from Southeast Asia, the Hmong, the Karen populations. They eat differently than I do, right? And if I'm going to be a doctor who's having this patient come in, they don't even speak my language. I need an interpreter, and then I'm going to try to talk to them about diet. I may have no understanding of what they eat on a regular basis. So it's incumbent upon me to learn that, number one. And number two, speak in a culturally sensitive way to those folks. And I can't just tell them, hey, you might want to stop eating, don't eat so much rice. To some people, that's like half of their diet, right? So, I mean, you have to do it in a way that makes sense to them and isn't saying, oh, your culture is bad because you eat all of this X carb. And it's funny because you could look at different cultures and everybody has their carb of choice, and they're all pretty detrimental to health, whether it's pasta or potatoes or rice or tortillas, you name it, it's a carb. Not that you can't have any of that, but you have to be aware of what those folks eat. Now, when you're talking about technology, and apps, boy, that's hard. I mean, if I have someone who is here just recently from Somalia, they don't speak English, they can navigate a phone kind of, but if I have an app that's only in English, I mean, obviously that's not going to help them at all. But then again, we can't make an app with 230 languages either. So what do we do about that? And I'm a good answer for that. I think that there are ways that AI could probably help with that in time as AI develops and gets smarter to help us with that sort of thing. But I think in the early parts of this, and not early, we're way behind the reality of this cultural issue. We're way behind it. But if we try to start making inroads into it, the first step is recognizing, wow, I need to think about this patient as a person that is different than I am. And I don't want to look like I'm preaching to them, telling them, you are bad. And sometimes that might be how it comes off to them. You have diabetes. Oh my gosh, I'm sick. I'm going to die. No, hold on. Let's talk about this. And this is what it means. And it takes, it's a challenge to educate sometimes for folks in different cultures that may not even know what diabetes means. I mean, I think the vast amount of Americans know what diabetes means, or at least they've heard of it, but they might not understand what that word diabetes means. And so you have to break it down. Blood sugars are too high. What does that mean? Oh, well, the food you eat, your body's not taking, not handling it, insulin resistance. Wow, you can get way down a road where they're just going to glaze over and say, I don't understand what you're saying. The right translator in there. And, what we had at one of the clinics I used to work at, we had folks that were from the community working at our clinic. And boy, that was great, because then they could talk to them like they're their neighbors, not like someone who looks like me. So, I mean, that's not always practical, but when you talk about different things that we can try to do to get ahead of this, those are kind of the things that I think of. Now, obviously, there are some languages that that work has been done in Spanish and French and some of the European languages, but there are so many others that we don't have inroads into to try to help folks.
Right, right. I think, like you mentioned, having a non-judgmental way of handling
Right,
everybody is, firstly very important. It is very difficult for everybody to relate to the doctor, but then again, one size doesn't fit all.
right,
Approach is also needed. Like, so if we understand that the cultural background is different, and we inculcate our medical practice and our dietary advice, and whatever advice we have to give them according to their culture, it really makes a big difference in their lives as well, like you mentioned,
right, right.
Dr. Smith. Dr. Smith, so we have some listener questions that they wanted to ask. So one of them would be like, how is it that I know that I'm at risk of going into frank diabetes? What is it that I need to look out for?
Sure. It's early on, it's really, really hard to know. I think the biggest clues are family history. And we're talking about type 2 diabetes now. Type
Right.
1, obviously different
Yes.
for juvenile diabetes. Type 2, there's often a family history. So your mom, your dad, you look at your family tree a little bit, your older brother, your older sister. Uh, and I encourage people who have a family history to really come in earlier and to start checking themselves with, fasting blood sugars during part of a physical, even sometimes in their 30s, we'll bring them in and check. So sometimes you just have to go to the doctor and get checked. There may not be a whole lot of symptoms there. There are symptoms of diabetes, but the symptoms you hear about, I'm urinating more, I'm very, very thirsty, I'm tired, I'm losing weight. That's when you really are way, way over the chain already. You're already there. So we want to get those folks before that. So your biggest clue is looking at your family history. And then if you happen to be overweight and a bit sedentary, that's maybe something to get in and see the doctor about anyway. But that may be another reason why we would want to check a fasting blood sugar on you. So, once a year to have a physical done and get a fasting blood sugar, even if you don't have symptoms, would be something I would recommend. For general, I mean, everybody should have a physical, right? Every year. It becomes more important as you get over 40. But if you have a family history, we would want to bring you in sooner than that and do some checks on a regular basis before that.
And how would you recommend, like, there was another question, how frequently should a person who has pre-diabetes be visiting their doctor?
So that's a good question, depending on how we're going to create the care model, right? So in a standard doctor dominated world, we would bring you in every 3 to 6 months and have those sugar tests run again, fasting blood sugar, A1C. I was a bit more aggressive with that personally. I'd try to get them to come every 3 months to get checked. Nowadays, if we're going to try to revamp the care model a little bit, maybe we think about it differently. Maybe we think about more touch points virtually, using data on the app that gets sent to me. I think there are different ways that we could explore that. And I think that almost has to be an individual discussion with your provider of how much you're willing to do, as a provider, more the better, right? But If at the bare minimum, I would want to check their sugars every 3 months to see what they're trending.
Mm. And would it be worthwhile meeting a behavioral specialist, even as a preventive measure for a person who already has prediabetes or type 2 diabetes?
The answer unequivocally to me is yes. I think that in the world of 2025, there's still insurance barriers sometimes, it's cost, it's time. But these visits, again, can be done virtually, sitting at home with a provider somewhere else and having a discussion like we're having over a virtual connection can save time with travel and driving and all of that, much more convenient. And then I think also if we think about wellness apps and things that we can connect people to with technology could be a way to do that as well. But I think the answer to me in a perfect world is yes, everyone with prediabetes or a tendency to high blood sugars, I'd get them in with somebody to talk about their mental wellness, how they're doing that way, diet, exercise, all of that as a base to this treatment.
Okay, wonderful. And what is your advice to patients in terms of how should they be prepared in going to their doctor? What is it that they need to like pre-plan before they meet their doctor?
As I was doing these visits, when I had a very, very busy primary care practice, I loved it when people came prepared. So when I first started being a doctor, I was annoyed by people who would bring in a list of 5 or 6 questions. I grew quickly to love that because then we're organized, right? You can hit these questions, boom, 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 boom. Let's talk about them all. Let's take care of your question. So if you have a question, don't be afraid to ask your provider. That's what you're there for. So if you can come prepared, that's great. Also, if you could know the medicines you're on, how many times a day you take them, what the dosage is. If you have an app that does that for you, that's great. But having a knowledge of what medicines you're on, your medical conditions, and your family history is so important to me as a provider so that I can make a really good plan for you. And then if you have data, if you have your glucose monitor, bring it in with you. If you have an app that connects to your CGM, bring that in with you. And we can sit down and we can look at it right there. So the more you can be prepared for that by doing those things, the more efficient I can be in a visit with you, and the more we can get done.
Nice. And what are the some of the tools and resources that you would provide your patients in terms of helping with better management of their diabetes? And you touched upon some of the wellness apps and health apps, and what is it in general that a patient should be using or utilizing to help with their diabetes management?
Again, I'll kind of skirt that by saying it's an individual decision. It depends on what the patient is going to be willing to do. In a perfect world, again, I would love them all to have CGMs on with an app to connect to in their phone that could bring that into me. They would have, my organization's my chart, if you will, or whatever equivalent patient portal that we can communicate that way with them. I would hope that I would have a really great team around me that would connect with them either virtually or by the phone or somehow, through as we go. And yeah, I think getting them sort of a resource list of really great websites that we trust, we meaning the organization I work for, or me myself, or to get them more information because, again, still, I guess we're calling this the information age, right? Everybody wants more information. And so the more information, good information, I don't want them just Googling, how do I fix diabetes and coming up with crazy things, but good reputable websites and ways to, I think it's really important to give them the resource to how do you connect to me? Right?
Mhm.
You may not get me, but you're going to get someone on my care team. And most of the time, they're going to take care of those questions. But if they don't, they're going to come to me and I'm going to make that decision. So telling them, this is how you get a hold of me. And don't be afraid to use this tool.
Right. Right. Very well said. Dr. Smith, one last thing. You talked about trust.
Yeah.
Now, it's very important that, because there are a lot of healthcare programs out there. There are a lot of health and wellness apps out there, and it becomes very difficult to understand which one to rely on. If you can give us, like, three parameters where, what is it that a person should look at in terms of, I can probably go with this one. Uh,
Hmm.
what would that be?
I think a complete package of, you don't want something that just does one thing here. I think we've made clear in this podcast, treating diabetes is a net you have to cast wide, right? Something that's going to give you some advice on how to manage your sugars and your diet, but also is going to encourage you to exercise and figure out ways of connecting to your Apple Watch or your Fitbit or whatever to take a look at your exercise patterns, encouraging you, providing positive reinforcement. And, a really great app would connect then somehow either to your care team or to the care team at that app that can then say, oh, this is bad. We need to send this along to someone. Um, I'm a big privacy person, so you want to make sure that the app, takes care of your data and isn't doing crazy things with your data because it's you and it's very, very, health data is very, very important. And we have to make sure that those things are tended very carefully. And I think one that is really kind of always thinking the next step, what is the next step that we can do? So adding features to the app is not just a kind of a flatline app that doesn't really grow and change over time. It's a hard one, but I think, because it is hard for just the general public to say, well, I got 6 apps in front of me. How do I know which one is the best? I don't have a really great answer early to say, well, just pick one or look at the reviews or look at how much traffic it has on it. I mean, obviously, if you have an app that has, 1 million users and then you have another one with 300, that's an indicator, but not always. I mean, you can have a really great app, but it's just not known yet, So I think there's a lot of factors in that. I think to me, as I mentioned earlier, demonstrating effectiveness. I mean, if this app comes out and says, look, here our users have shown a decrease in their A1C in the first 6 months by 13%, making up numbers. But that's big, right? And so as opposed to an app that just doesn't have any results published at all. I think that would be something I would look at. It's almost like an Airbnb with 2 reviews, or do you trust one that has 300 and they're all 4.9, right? I mean, that's the hard thing for the new apps when they first come out. But, in time when the new apps get out there and they show effectiveness, show your work, just like in school, show your work. And that is what I would suggest to look at.
Very well said. So it sums up kind of what we'd already discussed, bringing multiple disciplines in
Yep.
one
Yep.
place, and also, like, showing the effectiveness of the program. I would like to add three more points, if I may. So,
Of course.
a lot of times, when a person chooses an app, I think there has to be some alignment with their goals. I think
Yes.
what they feel they want to achieve has to be aligned with what the app is or the wellness program is going to help you achieve. But also, it has to be realistic, is my second point that I would want to make. So it has to be that, okay, I'm not going to have you drop your BMI from X to, like, 100% or 50% Y. So that's, an unrealistic goal. And that should, make you wonder, I mean, how is it possible? And then the third point is it really sustainable? So if they are giving some unrealistic goal, would it be possible for you to sustain it for long? Because ultimately, for most part, most people are able to lose the weight or they lose the BMI that they have gained, and able to, cut down on their glucose levels. But then once the weight comes back on, suddenly the diabetes is going to come back with a vengeance.
Right.
So that is what we want to look at. So that sustainability has to be definitely be there. Would be my 3 points into this. But
I think those are fantastic. And sustainability goes to my last point, which is growth, right? And change and adaptability of the app. If you see one that's been around who's constantly adding new features or at least growing what they're offering, that's how you can be successful with that too, I think, because you're incorporating all of those things.
great. Dr. Smith, I've had a wonderful time
Yeah,
today, and
me too.
these discussions have been fantastic. I'm sure the listeners are really going to enjoy with all the contributions, all the thoughts that you have portrayed today. And thank you for your time today and being here today.
Happy to do it. Really enjoyed it. Thank you.
Same here. Thank you so much.